Hi everyone. We have two musculoskeleton um, videos for this week, and this one is very short, and this is on the fractures. So a little bit about bone cells. We have our modeling and our remodeling that you learned in A&P, which is the osteoblast, B for bone building, and then osteocytes, which are the mature osteoblasts. And then our remodeling, we have our osteoclasts. So they reabsorb and degrade existing bone, which is good because then it makes room for the new bone to grow. So it's part of the cycling of bone health. Here's a small diagram for you in case you would prefer that. And it's just talking about the osteocytes. It's showing you the clasts, and then here the osteoblasts, which are building. So we have to talk about, it's easy to, talk about a fracture. It can be caused by many different ways, one of them being falling, automobile accident, so many ways to cause a fracture. I've had a few in my lifetime. But once you do have a fracture, if it is approximated, meaning that it is lined up properly, or after the fracture, the surgeon or the physician aligns your bone, then the healing process can begin. And it starts with a hematoma. So it starts with a hematoma as far as, these fibrinogens and blood cells going in to heal the bone itself. Once that cycle has completed its circle, so to speak, then what it does is it has a conversion of granulation to soft callus. So now, the bone is starting to heal, with that inflammation and the RBCs coming to that area, it's starting to heal, and it's starting to really grow new bone, but in the form of soft callus. Those osteoblasts also, what they do is they temporarily form hard calluses or formations. And so that is the beginning of some hardened areas starting to glue these two pieces of bone together. And then finally, there's remodeling, where those small bone fragments are removed by the osteoclast. So the small fragments of the broken bone are consumed by those osteoclasts. And then you start to have a strong bone. As you know, this takes about anywhere from 6 to 8 weeks to happen from here to here once it is in alignment with itself. So the meds that we use for when people have fractures, we do have muscle relaxants such as baclofen and dantrolene, which we've spoken about. We have benzodiazepines as well. So lorazepam, typically that is used for more anxiety, but it can also help relax those muscles and decrease the pain. Anti-inflammatories such as salicylates and NSAIDs, ibuprofen, ketorolac. Ketorolac is very common in bone fractures. Also, acetaminophen is very common in bone fractures, and we'll give it in a glass vial, IV piggyback, to administer usually 3 times a day, 1,000 milligrams, 3 times a day, IV piggyback. Believe it or not, it works much better than the PO form, and especially for these fractures or any type of orthopedic surgery when they get the IV Tylenol. It works wonders for their pain management. And then lastly, we do have opioids, morphine, hydrocodone, hydromorphone, for hopefully just breakthrough pain. There's other things that go along with fractures and pain as well. We can have lidocaine patches. The physician during the surgery can do a nerve block, which actually blocks the pain from that particular limb for a period of time. The biggest thing with fractures are complications. So we talked about that hematoma that forms when that break first occurs. And so you're really at risk at that point for a DVT, deep vein thrombosis, so a blood clot in a deep vein. Because that break itself can cause damage to that vessel wall. And then as it's starting to heal, we've got a stasis of blood buildup, and so that could kind of travel through the venous system and stop somewhere, causing a deep vein thrombosis. So typically your fracture patients will be on some type of anticoagulant. Usually it's going to be a 5,000 units of heparin or a low molecular weight heparin, such as Lovenox. They are also at risk for infection, cellulitis, which is an infection right underneath the skin, osteomyelitis, infection in the bone, and then of course systemic infections, because if these fractures are open, then you're going to have a risk for systemic infection. Also, if they had surgery, so they can have an ORIF, which is an open reduction internal fixation, and that is when the surgery has to be, the leg has to be cut open or the arm has to be cut open. They put pins in and then they close you up. There's also external fixation, which is when they usually open you up and put pins in as well. But then the pins are also on the outside of the leg with kind of a metal brace around it. You have to do pin care for that, and you have to do it at least twice a day to help prevent infections from and bacteria from crawling into the leg from using those pins as a mode of transportation. With our operations, we use that skip measure, remember, so we're going to have antibiotics prior to incision time, and then for the next 24 hours. So a fat emboli is also another complication. And so these are things that, all of these complications are things that you as a nurse on the floor need to watch out for. And then you need to look for signs and symptoms of infection, signs and symptoms of a DVT, signs and symptoms of pain management and circulation in the extremities of the fracture site. A fat embolism is a complication of a long bone fracture. So basically what happens is it's typically will be the femur, a very large bone. And when you break a large bone and, it kind of cracks open a bit, the fat globules that are in the bone marrow can actually come out and go into the bloodstream. So where those fat emboli typically land is in the lungs. And so if you have a patient that has had a large bone fracture and you see them really showing signs of maybe a pulmonary embolism, so a blood clot in the lungs, which would be shortness of breath, tachycardia, then you might think it's either a pulmonary embolism or a fat embolism. Obviously, we wouldn't treat this unless we knew what type of embolism it was, but the fat embolism is much harder to treat because with the pulmonary embolism, the blood clot, we can give them anticoagulants, we can stop it from growing at least, and then if need be, they can go in for interventions to get that blood clot out. But with a fat embolism, it's very, very difficult to do that. They might try interventions, but there's nothing to dissolve it. You just have to wait it out and let it dissolve by itself unless they decide to do surgery if they feel like they can get it out. But a fat emboli is just as deadly as a pulmonary embolism, sometimes worse. Because there's no treatment for it that is nice and quick and easy. However, the pulmonary embolisms are far more prevalent than a fat embolism, okay? So large bone fracture, watch out for signs and symptoms of respiratory failure because it could be a fat emboli. The other complication is a compartment syndrome. This is a good picture because it shows swelling in the hand. So what happens with compartment syndrome is that you can see all of the fluid and everything in here. What happens with compartment syndrome is with the swelling that goes on with the broken arm or the broken leg, you can get so much swelling that your skin will not stretch anymore. Okay, so the outside section of your skin, there's no more flexibility in it. So that pressure, that increased pressure, has to have somewhere to go. So what it does is it starts pushing inwards towards the bone rather than coming out. It pushes inwards. And what that does is it then stops the arterial circulation. Okay, stops the arterial circulation. So now we're looking at a potential amputation if this is not caught immediately. What they do for this, unfortunately, is they make an incision. So they would make an incision, whether it be on the other side of the arm or this side of the arm, and it's a straight down incision, and it's almost like a fillet. They fillet open the arm so that the actual inflammation has somewhere to go. And it's called a fasciotomy because they have to cut down to the fasciotomy area of deep down into the arm. Once the swelling goes down, then they can sew it back up, but a lot of times that is hard to do because of the way that the inflammation and the way that that arm or leg has been filleted open. And so typically we're talking about skin grafts. This is extremely important because, like I said, if it's not caught in time, then we're talking about an amputation. And as you can see here, within 4 to 6 hours of onset of this, you're going to have neurovascular damage that is irreversible. And after 24 to 48 hours without doing anything about this, then your limb is classified as useless. And that's when a amputation would be looked at. So important things to remember with fractures is the pain should be lessening. If they do have a cast on, and even if they don't, but especially with a cast, you need to be monitoring the cast, their perfusion, whether it be in their fingertips or on their toes. You need to be checking every time you go into that room. Just do a cap refill and make sure that it is perfusing, which means that it's less than 3 seconds. The patients that you will take care of in the hospital will not have a hard cast on. It will typically just be a very soft cast because they expect that limb to swell somewhat, and so they're not going to put a hard cast on that patient. So you need to make sure that circulation is good and that the limb is being perfused again. Those are really very important things. Monitor for that DVT and signs and symptoms of infection. Do pin care and monitor for any respiratory problems. So as you can see, the fracture itself is minimal as far as what you can do for the patient. So you are basically taking care of their signs and symptoms and monitoring for any of these harsh complications that can occur with a fracture.